Good afternoon, my seniors and colleagues. I'll be talking about positioning in spine surgery. So let's look at the principles on what this is based on. First is to have an optimum surgical access, so for the surgeon to be able to complete the job safely. Next is safety of the patient, so as to prevent any complications, which we will have a look in a minute. Respecting the spinal alignment, especially in unstable spinal fractures, and for surgeon ergonomics. Now, if you look at this list of complications associated with prone positioning, you can see that those with the ocular complications due to increased intraocular pressure takes the topmost position, followed by those due to neuropraxia or nerve injury or nerve stretches, then by the myocutaneous complications like compartment syndrome or pressure ulcers. Now, if you look at the physiologic changes associated with prone positioning, you can see that the major parameter or the most important change is in the cardiovascular parameters with reduced stroke volume and therefore cardiac output and cardiac index. There also is increased abdominal pressure when you shift the patient from supine to prone position.
And you position the patient prone, and there is also increased central venous pressure. The airway pressure changes from supine to prone, so you should be keeping an eye on as to how much is the change. And the usual recommendation is not should be more than 10 to 12 centimeters of water. So that is something that you should keep an eye on. And also the pressure points in thin skinny patient is something that we should be watchful about. Now, if you look at this diagram, it just summarizes how the abdominal pressure increases and the pressure in the inferior vena cava also increases when the patient is on the prone position, and then precipitates the backward pressure in the Batson venous plexus and then into the epidural veins. Now, it is very common experience for all of us that even if we fiddle a bit around these veins, we end up injuring them, and that can cause a lot of bleeding during the surgery. This is because these veins are thin-walled, delicate. They don't have any muscles, they don't have any walls, so they are very easy to bleed, and that bleeding can actually lead to poor operative field, which can cause complications. Like if I just remember the incidents that happened in one of the trusts I was working previously with, where a trainee surgeon was operating a cauda equina syndrome and had an epidural bleeding, ended up having a dural tear and didn't complete the job, ended up closing the patient, and the patient was rescanned with a big disc, persistent symptoms of cauda equina. The trust ended up in a real medical legal problem and ended up paying millions. So it can be as bad as that if your operating field is not really good. So that can happen just because of poor positioning. So it does seem to be not so important, but yes, if you have these problems, then you can end up in real trouble. Obviously, if you're not able to see well, that can also end up increasing the duration of your surgery. Pressure sores and other complications we already discussed about, so yeah, that can also be one of the complications of poor positioning. So what are the things we should be looking at? So just to highlight the things that we should be mindful about: turning the patient from supine to prone, considering the position of head with respect to heart, looking at the eyes or orbits, caring for the endotracheal tube. It's not just surgery. We should also be with the anesthetist, having good communication with them, talking about the tube positioning and also care for that. Prevent its dislodgement. Check the position of neck, bolsters and the distance of bolsters from each other. Shoulders and arms, securing the private parts and breast, padding them well. And also plan for C-arm so that you can get in and out of the operative field well. So the care of the patient with positioning starts right from the anesthesia when the anesthetist is intubating the patient. So one of the spinal team members should go and supervise or give support to the head if there is ankylosed spine or if there's an unstable cervical spine fracture. So there are cases reported where in an ankylosing spine, the anesthetist ended up extending the neck too much and have had chance fractures of the cervical spine. So it is very important to be mindful about this. Now, turning the patient from supine to prone is something that should be a one single coordinated soft move, and if you need enough hands, please ask for help. I recommend there should be 2 people on one side, on each side, and the anesthetist takes care of the head part. So 5 people should be enough to make that one single smooth move. This is something fancy that we used few times in the setup in the UK, not so very common in India. But so this setup is like Allen table flip, where you use for large patients with unstable fractures which are difficult to turn. So this is basically the patient is sandwiched between these 2 tables at the top and the bottom, and 2 people are required to flip this table 180 degrees, but I'm not very fan of this. I still like the traditional way of doing it in one single controlled roll. Head above heart is something that has shown that the Reuel-Trans-Lundberg position, about 5 to 10 degrees of tilt at the head end, can reduce the ocular complications. So I try my best whenever I can. I just tilt the head a bit. I've seen few people still operating with turning the neck on one side, and that is something that I don't really recommend because of especially in the patients with severe spondylotic cervical myelopathy that may end up having problems. So the head should be in line with the neck and straight. That can be done with various ways. Now, the one shown in this picture is a horseshoe support. And that can be attached to the just normal top end of the Mackie table with these two knobs at the top and the bottom, which you can change that to manipulate the position. But my personal favorite is this mirror head foam, which is very easy to obtain, and you can get it in any surgical store. And there is a mirror, so the anesthetists are usually happy with this one. The tube can be seen, eyes can be seen very well. So I usually prefer to have this one. This is the one we used in Sion Hospital in 2014. This was devised by my head in the hospital. We used to put these tongs and support that on the side support. You may attach the traction if you wish to. Neck position is very important, especially in the cervical spine surgeries, or in all surgeries basically, but in the cervical spine surgeries as well. If you see this picture, one in the flexion, the ligament of flavum is really, really tight, and the one in the extension, it just buckles up, and that occupies the space available for quad. So too much of flexion can stretch the quad excessively, especially if there is tight narrowing in the canal, so try not to overdo it. Likewise, extension as well can cause a buckling of the ligament of flavum and can compromise the space for quad. Shoulders and arm, I prefer the one at the right side where the shoulders are less than 90 degrees. It is about 90 degrees extended, but I prefer to keep it less than 90 degrees. The elbows, I like it to be a little below the shoulders and adequately supported on the hand rest. Some people also use the one on the left, Superman prone surrender position. So the bolster distance should not be too far, should not be too close. If it's too close, it increases abdominal pressure, increases the intravenous pressure, and also bleeding. If the patient is thin, it can also sink in if the distance is too much. So just not too wide, not too close. And you can also choose to keep it horizontal. Hips and knees is something that you can use to your advantage. The one at the top picture is the patient lying on the Wilson frame, which has been jacked up, and the interlaminar space is opened up. So this you can use if you're performing a discectomy. It just gives you better access to enter the interlaminar space and access the disc. But I've seen complications with someone going through the bovie, entering the interlaminar space through the ligament of flavum and puncturing the dura. So you don't want to open it too much. That is advisable only for discectomy, and you should be knowing where you're going. When you're instrumenting the spine, like reducing the spondylolisthesis or fixing a few levels, it's advisable to respect the normal lordotic curve and not flex the hips a lot, or just keep it neutral, or you can also extend it a bit if needed. Pressure points, again, I can't stress this enough how important it is to secure the pressure points. So make sure that at the head end, shoulder, elbow, axilla, iliac crest, knees are all padded well. This is another common position that we usually use. I'm just going to run through quickly with this. Anesthesia trolley, I usually prefer it to be at the foot end of the patient. The tube position, I like it to go on the forehead and not on the either side, because it is not good for the assistant to pull the retractor. So I like it to on the forehead, and also put a gauze piece at the tube so that the drapes don't stick on the tube. Head and the neck, just slight extension and neutral if you can. But if the patient is bulky and short neck, then you might want to add a little extension if needed. Prefer to have a roll of the towel under the neck if you're going to put some instrumentation, or shoulder strap also to pull down the shoulders a bit if needed. Clamps and tongs if needed. I don't prefer for single level ACDF, but if for corpectomy 2 level or so, then I might add just clamps without traction and ask my assistant to pull it whenever I'm instrumenting the spine. So to summarize, pad all the pressure areas well. Ensure that eyes, abdomen, and genitals are free. Be extra careful for large-sized and skinny patients. Use the position to your advantage, and also consider C-arm in your planning so as to come in and out of the operative field easily. Thank you.